Hi, I'm Dr. Mirdad Ayadi, and I'm here to talk to you about Lewy body dementia. After Alzheimer's disease, Lewy body dementia is the second most common type of dementia. And this is a very challenging dementia for everyone, including physicians, family members, caregivers, memory care facilities, and even a skilled nursing home, and even in the hospital. Be with me, and I'm going to talk to you today about what is Lewy body dementia and what are the symptoms. And in the next videos, I will explain to you how to manage Lewy body dementia. I'm always getting this question as a geriatrician from patients and the family and the public. What is exactly dementia? Dementia is technically a very general term. It's progression, loss of the cognition. It's not normal. It's actually not part of the aging process. A lot of people think when I forget something, it's maybe aging brain. Yes, that is correct. But dementia is a little bit beyond of what we think aging brain is. A disease, is a progressive memory loss that also affect other part of the brain function. The next thing that we're going to talk is about type of dementia. And we have many diseases can cause dementia. About 100 diseases can cause dementia. But the most common cause of dementia are Alzheimer's dementia, and the second to it is Lewy body dementia, vascular dementia, and then frontotemporal dementia, which has happened mainly in the younger population. But many of this dementia can overlap with each other. We have many times the patient have Alzheimer's dementia and at the same time vascular dementia. We have many times Alzheimer and Lewy body dementia together. These diseases can overlap with each other. Let's just briefly talk about symptoms of dementia. And as you know, that memory loss, it's the main part of the dementia, which first initially start with the short-term memory loss and later will be long-term memory loss. And we will talk about it more in the next videos about what it means with memory loss and how it's going to be presented and what's the difference between memory loss in the different part of the dementia. And other things that can happen in the people with dementia is a communication problems. They have a hard time to finding words to make in a statement, to make a sentence, to make a speech. And that's something that we can see in people with dementia can happen. Disorientation. A lot of time they're not aware of the time, year, date. For example, they have a hard time to really follow the calendars. Sometimes disorientation can be a problem with the place. For example, the loved one drive to a grocery store and they don't know how to drive back home. That kind of disorientation can happen. Also, they have a problem with the planning and organizing things. I usually get, as a geriatrician, the most call for the consultation around the holiday time, especially Thanksgiving time. I get a call from the children, they're coming to see the parents, and the first thing they notice that, for example, mom was always able to throw a big party for the Thanksgiving, but this year she had a hard time to planning the party, putting all together, who are the guests, what are the recipes, what she wants to cook, or many other things similar to that. Other things that can happen, they can be mood change, they can be depressed, they can be anxious, they can be very, very restless as well. And other things that definitely personality change. The most sad symptoms of dementia that affects the people around, because the first thing they always telling me that this is not my dad, this is not my mom, this is not my partner. They definitely notice that there's definitely a shift in the personality as well. And other things is some of the psychotic symptoms, which is the most hard and challenging part of the dementia. They can be extremely agitated, they can be verbally aggressive, they can have delusion, they can have illusion, they can have hallucination, and many other symptoms that we can see in these people. Briefly, I wanted to say that the first disease that has been diagnosed, and we will talk more in details about it, was Alzheimer's disease by Dr. Alzheimer. In June 1903, a researcher and a pathologist by the name of Dr. Alzheimer was invited to open up a psychiatry clinic in Munchen in Germany. There was a lady, name was Augustine. She was diagnosed with schizophrenia, But Dr. Alzheimer was suspicious about the diagnosis. And finally, he was able to find in autopsy, means after the death, with the brain analysis, that this is not a schizophrenia. It was 1906 that Dr. Alzheimer gave a very famous talk to the 37th Congress of Psychiatrists in southern Germany and announced this disease for the first time as Alzheimer's disease. And as we talk in the past, and you can see in my other videos, and we will talk more details in the future, there are abnormal proteins that can be found in people with Alzheimer's dementia. And one of them is an amyloid protein, which is technically is a normal protein, but when they become a clamp of plaque, we call beta amyloid protein, that can be problematic because they can technically disconnect a neuron's synapses from each other. And also the other protein that we found, and they're also very, very problematic, is a tau protein that can make a tangles, and that tangles also disconnect neurons from each other. This is the principle and basic that we know about Alzheimer's disease. But in Lewy body, there is a small Lewy bodies inside the cell, as I'm showing to you here, that actually started to inside the neurons and brain cells develop. This Lewy body are not a plaque or tangles, but is a protein we call synuclein, the same protein found in the people of the brain of the people with the Parkinson's disease. Alpha-synuclein is expressed through the brain and is localized as a presynaptic terminals. We do not understand the function and the rule, but neuroscientists think that it affects the neurotransmitter release, the enzyme that actually are connecting neurons with each other. Under these circumstances that we still don't understand, this alpha-synuclein undergoes to structural change and technically organize and deposit as a Lewy body. And that Lewy body inside the brain cells are the fundamental of the disease that we are talking about it today. What depends on localization of Lewy body in the different part of the brain, then we are expecting different symptoms. For example, as we will discuss soon, we, for example, see visual hallucination, one of the hallmark of the Lewy body, because technically this Lewy body cells start to develop more on the temporal lobe of the brain. Or, for example, if this Lewy body is going to deposit more in the spinal cord and the hypothalamus area or vagus nerve, then we have many autonomic symptoms that I'm explaining to you, like blood pressure fluctuations, syncope, falls, and many other symptoms that we are going to talk. Then technically the traffic of this Lewy body in the different part of the brain can cause the different symptoms that we see in this disease. Technically, the symptoms of the Lewy body dementia is based on first memory loss, as it is a dementia, and then we have a core clinical features, and then we have supportive clinical features, which we're going to explain about the symptoms. When we talk about memory loss in people with Lewy body dementia, unlike the people with Alzheimer's disease, which typically present with memory loss as the first symptoms of the disease, mainly prominent cognitive deficit, Lewy body dementia, it mainly first comes with the attention problem. And then we see the executive function is getting less. And also visual spatial function is getting worse. Memory affects later in the course of the disease. And this is so important because when we do testing of these people, we see more impairment in visual spatial condition, and which is condition that it makes difficult to process visual information and understand spatial relationship that affects a person's ability to judge distance, navigate in a space, recognize objects, read, understand the depth, and technically not able to translate what they see. People with visual spatial impairment, they have trouble with using stairs. They fall a lot because they miss the stairs. And this is one of the first things that we see in these people. Parking a car, it's going to be extremely difficult for them. And this is one of the early signs of this disease. They have a hard time to put the car on the curbside. And picking up objects going to be extremely hard. They're starting to bumping into things around the house. They're having a very hard time to tying their shoes and even using the scissors. And also, the later we see that because of executive function effect, the routes and schedules going to be especially difficult for them. Visual spatial impairment can be very dangerous, especially when they're driving. It can make them difficult to turn and park with their car. And this is one of the first things that we can actually see in these people. When it comes to the core clinical features, first thing is a cognitive fluctuation. I will explain to you. This is very important to understand about this disease. Visual hallucination, which is a very main core of the clinical features, and a sleep disorder or REM sleep behavioral issue, which is rapid eye movement sleep disorder, which I'm explaining to you in details. Cognitive fluctuation. It's a very common and very painful for family member to see the loved one with a fluctuation in their cognition. What does it mean with that? It means that they can be okay in 1 hour, and then suddenly in the couple hours, they can be severely confused. And sometimes it's just very hard for family members because a lot of time they see, for example, the loved one doing very well, like they don't have any dementia at all. In like a couple hours or half a day, they see them very, very confused. And that sometimes this fluctuation can be extremely severe. A patient can be completely zone out. And sometimes caregivers or family members think that patient has loss of consciousness. And this is one of the reasons that they ask to transferring them to emergency room. Sometimes they can be completely unresponsive. They even not able to talk. Family members think that loved one has a stroke or has a seizure. As I said, sometimes they can be extremely sleepy and tired and sleep for 12 hours, 15 hours, 16 hours. Sometimes they can have very bizarre manners and behavior. In people with Lewy body dementia, we see that they can take naps for hours. They can have more staring spells. The speech can be sometimes very disorganized, and they're very, very tired during the daytime. Alzheimer people, they're not as like people with Lewy body dementia. The people with Alzheimer dementia, they can have fluctuation in cognition, but it's not very sudden and rapid. Like, for example, people with Alzheimer dementia, they can have a good days and they can have a bad days. Monday and Tuesday, they're extremely doing well. Even they remember some stuff that surprise the family, and sometimes asking question, is this person really have dementia? And the next day is totally a different person. Very forgetful, very confused, but definitely there's not like hour, like half a day or 2 hours. 2 hours extremely good, and another 2 hours extremely confused and a very different person, bizarre behavior, or very sleepy, so tired, even without doing anything. This is kind of like a part of the core clinical feature of people with Lewy body dementia. Very common in people with Lewy body and one of the early signs is visual hallucination. Even before Parkinsonian symptoms, they can have visual hallucination. This is rare in people with Alzheimer dementia in early stages. And even in people with Parkinson's disease dementia is less common than Lewy body dementia. We see more visual hallucination in Parkinson's disease dementia when we give them the Parkinson medication, anti-Parkinson medication. But in people with Lewy body dementia, it can happen in any stages. Even without medication, they can have visual hallucination, kind of like a core clinical feature of this disease. What are these visual hallucinations are? Most of the time, patients see small children, images of people, small animals. Sometimes they just see something briefly out of the corner of their eyes, or sometimes they can see very complex things, like for example, they have a dialogue with their deceased loved one. REM sleep, or rapid eye movement sleep behavioral disturbances, that can happen years, even 10 to 20 years before the clinical diagnosis of Lewy body dementia. And what is that? They actually, people with this disorder, they're starting to acting out their dreams during the rapid eye movement. Because in normal situation, in the rapid eye movement sleep phase, we're not supposed to acting out our dreams. If we do it, then we're going to have a lot of the movement in the bed with each single dreams that we have. And that can be sometimes a very violent movement. We can do punching, think about that we're thinking about we're fighting with someone in our dreams, or boxing with someone in our dreams. It can be kicking, trashing, and that sometimes can be very abnormal noise in the sleep. And this is so important because if we're not able to provide a safe environment for patients, they can have self-injuries in the bed. They can easily fall off from the bed. Or if they have a partner in the bed, they can easily hit the partner at the bed. And this is why the safety around the bed and a sleep environment is extremely crucial. That also can happen in people with Parkinson's disease, dementia. But it's a very, very challenging symptoms, and it's very hard to be treated. Beside of the fluctuation of cognition and visual hallucination and REM behavioral sleep disorder, Parkinsonism is look like Parkinson's disease, Parkinsonian symptoms as well. We say that it's one of the major core feature of the Lewy body dementia. It happens in 90% of the cases, and that can be resting tremor. People can have a tremor even with action. But for example, most of the time they try to hide their hands because they have tremor. They can have rigidity. What does it mean with rigidity? When muscles in arms, legs, and or body becomes very stiff, kind of like inflexible. It's going to be very difficult to perform everyday tasks. For example, they have a hard time to write. They have a hard time to swallow. And sometimes objectively, people think the muscles have a spasm. That's called rigidity. One of the other symptoms is the gait and balance. A typical gait and balance of people with Parkinsonian, very slow, very shuffling, and you can easily see people with the Parkinsonian gait feature. Bradykinesia, which is technically a slowness of their movement. For example, they have a difficulty starting any movement. Like for example, they have a very slow standing up. We see that, for example, their automatic movements going to be reduced. Blinking, one of the things that you can see in these people, they have the number of the blinkings in a minute is going to be reduced significantly. When they walk, you can look at their swinging of their arms, and you can definitely see that the swinging of their arms is going to be reduced. One of the other things that you see, they are abnormally very still. And when you look at their face, they see the facial expression has been decreased. It looks like they have a very, very masked face. When we look at the people with Lewy body dementia compared to Parkinson's disease people, which they have all these symptoms, the people with Lewy body dementia, they have milder symptoms. It also can be in some Lewy body dementia very severe, but overall, when you compare to Parkinson, they have milder symptoms compared of the people with Parkinson's disease. So far, we talked about clinical core feature. But here I'm going to talk about supportive symptoms, which these symptoms also can be part of the Lewy body dementia. One of the first symptoms is antipsychotic sensitivity. Many of these people get agitated, they go see a doctor, they have delusion, visual hallucination, and we prescribe for them antipsychotic. I will explain to you. They become much worse when we give him this kind of medication. The other problem is a postural instability and fall. I will explain to you very soon. They can have syncope or transient loss of consciousness. I will explain. Autonomic dysfunction. They can have excessive daytime sleepiness, means they sleep for a long hours. That part of the clinical core feature I explained to you, part of the cognition fluctuation. They can sleep for hours and hours and hours. And they can have also decreased smell sensation. And one of the other things is apathy and depression and anxiety. Be with me, I will explain to you a little bit about this supportive symptoms. A very challenging situation in people with the Lewy body dementia. 30 to 50% of people with Lewy body dementia, they have significant sensitivity to antipsychotic medication. We give them for their agitation, for their hallucination and other symptoms, and they can have acute reaction, can have for example, the Parkinsonian symptoms can be significantly worse. For their tremor, their rigidity, their gait, they're all getting much worse. They can even have worsening of the fluctuation of their cognition. For example, they can have complete loss of consciousness when we give them antipsychotic medication. We give them a lot of time this medication to help with their agitation, but at the consequence, we see their agitation and anxiety actually getting worse with these medications. We have very limited options in these people. This is a very important topic. I will explain more about it in the next videos, but this really require an expert a geriatrician or neurologist or psychiatrist that be familiar with this disease and prescribe a correct medication for this problem. As I explained, postural instability and fall, it's very common in people with Lewy body dementia. 1/3 of patients, they can have fall because of that, and they cannot stand up easily. That can be related to the Parkinsonian problem, or it can be to the situation that we call autonomic dysfunction. They can have a low blood pressure when they stand up. We call this term orthostatic hypotension. Means, for example, if their blood pressure is 120 when they're sitting, when they're standing up, their systolic blood pressure can drop to 90, 80. And also the cognitive fluctuation that I explained to you earlier, that also can cause postural instability. Imagine that in like 2 hours, they're doing extremely well. They start to walk, they do exercise, and suddenly the body and the brain start to have fluctuations in cognition. That's why they can have fall and postural instability. Extremely challenging and always cause problem more. They can have injuries, they can have hip fracture, spinal fracture, and also fear of fall, which it makes them to have technically stop walking, and their mobility is going to decrease significantly. Another challenge in people with Lewy body dementia, transient loss of consciousness, are very common. They can be completely awake but mute and stare blankly. Sometimes they can be completely zoned out, completely unresponsive. The caregiver goes to the bedside or to the chairs, and even they call, they talk to them, they even rub their shoulder, they not respond anything at all. They can be severely frozen. These are the very scary symptoms. Most of the time when the family members or loved one, they see that, they think the loved one had a stroke, they call 911, they take them to emergency room, they do CT scan, all the tests, there's no stroke, and they just discharge them back home. This is part of the Lewy body dementia. They can have this transient loss of consciousness as a part of the symptoms. Autonomic dysfunction, as I explained, can be extremely challenging. Orthostatic hypotension, I explained, they have a low blood pressure when they change their position from lying down to sitting or sitting to standing. The blood pressure, especially systolic blood pressure, drops, make them very dizzy, lightheaded, increased risk of falls. But also they can have severe constipation. Severe constipation, even they're drinking prune juice or taking a stool softener, they have a very hard time to go to the bathroom. And this is a part of the autonomic dysfunction because intestinal motility is getting affected. The same thing happen in the bladder. They can have retention of the urine, not able to empty their bladder very well. They can have urine incontinence, and that part of the autonomic dysfunction that we see in people. And they can also have abnormal sweating in people with the Lewy body dementia. Apathy is other part of the disease, which is technically no motivation, no energy or interest. A lot of people think apathy is a depression, but it's not necessarily depression. It can associate it with depression in many cases, but it technically is a part of the neurodegenerative disease. And many times when the people think about lack of energy, and patients complain that I don't have any energy, I feel very fatigued, they feel that there's a vitamin deficiency or they wanted to give them some supplement to help them to boost their energy. This is not about energy. This is about brain. This is about neurodegeneration, that they do not have interest or motivation to do anything. And it's very, very hard to treat the apathy. And we will talk more about some of the options that we have for treatments for these people, but it's extremely complicated situation of people with Lewy body dementia. Other situation is depression and anxiety. Depression is very common in people with Lewy body dementia, and it's interesting that some of the study shows people with the Lewy body dementia, they have more depression compared to the Alzheimer patients or Parkinson's disease dementia. On the other side, anxiety is very common. About 50% of people with the Lewy body dementia, more than people with Alzheimer dementia, they have more anxiety. And sometimes this anxiety can be panic attack. For no reason, they can have suddenly a panic attack without any triggers. And that's something that we can observe in people with Lewy body dementia. One of the biggest challenge that I will explain to you in the next video is about the treatment, because many of anti-anxiety, antidepressant medication can cause worsening of some of the symptoms, either Parkinsonian or REM behavioral sleep disorder can get worse with the typical serotonin medication that we use. I'm not saying we can't use, I will explain to you in the next videos, but overall it needs an expertise to really monitor and observe the other symptoms when you're treating depression and anxiety in people with the Lewy body dementia. It's not as simple that we give antidepressant to every person with Lewy body dementia without monitoring them, without explaining to the family member and caregivers about watching some of the other symptoms as may get worse with this kind of treatment. Let's talk about some other type of delusion and hallucination that also can be supportive of the disease. It's not that every patient with Lewy body, they have these symptoms, but there also can be observed in people with Lewy body dementia. One of them is auditory hallucination. It's not very common, but it happens in some cases as with the Lewy body dementia. They can hear music, or they can hear a TV is on in another room, which is not, or they can hear a ringing a telephone in another room, which is not there. The other type of the hallucination is olfactory or smelling hallucination. They can feel a good smell, like they feel flour or food, but also they can feel something bad, like a burning rubber or similar, but that also can be one of the supportive symptom as well. Other type of hallucination is a tactile hallucination. They feel something on a skin abnormally. For example, they feel an insect crawling on them, or there is a pet brushing against their legs or hands, like a cat or a dog is brushing against their hands or or their legs. They can have somatoform delusion. Can be medically unexplained symptoms, and which they can make them to have a trip to emergency room, do all the workup, nothing's going to come out, but that's kind of like a more somatoform delusion. They can have sometimes a very systemic delusion. It can be a false or fixed belief, and that can be very painful. For example, for people that are watching them, for example, they have the fixed belief that the place that they're living is not their home, even they're living in their own home, or the people in the TV or mirror are talking to them or speaking to them, or sometimes they feel the partner or caregiver is an imposter. These are kind of like a delusion and hallucination that sometimes we can see in people with the Lewy body dementia. I try to explain to you some of the major symptoms of the Lewy body dementia. Hope you understand the concept of Lewy body dementia. What is exactly Lewy body dementia? In the next sessions, I will explain to you more about how to diagnose and how to manage the Lewy body dementia as well. If you need more information, you always can go to some of the very helpful resources like Alzheimer Association or American Geriatric Society, which they have a lot of great information about this kind of disease. You can also always check our website or channel for some new videos as well. Hope it has been helpful for you.